invite Professor Eileen Boyle from Lille to talk again about the elderly.
Thank you. Introduction. So it's my pleasure to be here today and discuss the management of elderly patients with multiple myeloma. So we've heard a lot about the management of elderly patients. Yesterday, Professor Facon gave you an overview of how we manage such patients. Professor Monti told you about the transplant-eligible patients, and Dr. Alessandra La Rocca later on will tell you about the management of the frail and the geriatric assessment. So I just wanted to tell you today about how we manage elderly patients with myeloma that are not eligible for transplant, so the more frail patients. So we are convinced myeloma is a disease of the elderly. So most frequently the patients are diagnosed in between the ages of 65 and 74, with a median age of diagnosis of 69. So one question we could ask is it a separate disease? Like we would think about elderly Hodgkin's lymphoma being separate from standard young before 30 disease. So is there a difference in the myeloma of elderly patients? And the answer is probably no. When we look at the proportion of copy number abnormalities and structural abnormalities, there is no significant difference in the pattern and landscape. Although the French study did find a slightly more increased incidence of translocation T414 in these patients. On the mutational studies, there was no age-defining mutations that could be identified, suggesting this disease is probably the same as the one occurring in the younger counterparts. But what makes it specific is probably related to the patient. So the myeloma patient does have its own cytogenetics, its stage, its tumour burden, and its optimal treatment. But this disease occurs in a patient, in an ageing patient that develop specific processes defined by age and senescence. And another important fact to take into consideration is the different goals of treatment care a patient can have, a difference in expectation and understanding, and his own life expectancy that are important to take into account into the patient's management. And this is all, and Dr. Alessandra La Rocca will tell you more about the other important factors such as chronic illness, medication, and social and psychological supports that are required. And this leads us in unique situations where we have challenges in terms of toxicity, comorbidity, and compliance that need to be taken into account. And so one of the ways we have to make progress in the management of a disease is clinical trials. And we all know there is barriers to enrollment such patients in clinical trials. And they're multiple. They go from challenges in gaining information consent, in the way we can assess patients, in the logistical problems, the need for supportive medicine, and the possible protocol restrictions. But as far as myeloma is concerned, this population has been quite well represented in specifically designed clinical trials. And the first clinical trials we have were thalidomide based. And this is just an example of the IFM 9906 trials that, among others, led to the change in clinical practice, where the standard IMP where the thalidomide entered the standard of care for this patient. So this is just a review of a meta-analysis published by Failures, and just demonstrating that adding thalidomide to a backbone of nephron-prednisone would add 6 months in terms of PFS and 6 months in terms of OS. Similarly, the British group uses a slightly different backbone, still with an alkylating agent, thalidomide and dexamethasone in their CTD backbone. One of the main concerns about using a thalidomide backbone is probably neuropathy, with an incidence of grade 3 and 4 neuropathy that is quite significant, so it ranges from 0% in some trials to up to 9%, which makes it difficult to manage in the long term. And so slowly thalidomide was replaced by other agents. And the second backbone therapy that has been developed is the Velcade base. And so VNP became one of the standards of care. And this was just adding bortezomib to the standard methylprednisolone backbone. And so in this trial, there was a significant improvement in both time to progression and overall survival by adding bortezomib, which in the time of this paper was IV, and there was a significant impact in terms of both time to progression and overall survival. And so what happens if we changed slightly this proteasome inhibitor MP combination by adding a novel proteasome inhibitor that was carfilzomib. And this was moving forward to the KMP backbone, so using the MP backbone and adding either bortezomib or carfilzomib. So what is important to note in this Clarion trial is the scheduling of the carfilzomib and the dose, which was 36 milligrams per meter square, and for a fixed duration of 9 cycles. And so what was important to see that what it was in terms of PFS, there was no significant difference in time to progression in between the KNP arm and the VNP. And so, and this was seen across all subgroups. And so in terms of overall responses, there was no significant difference in terms of overall response, very good partial response, or complete response in between the two groups. And this was quite surprising. And so this study, there was a fixed number of cycles and a non-standard dosing of schedule of carfilzomib, which may explain that there was no statistical difference in terms of PFS between the KNP and the VNP arms. So in an updated analysis, the median OS was still not reached either in the KNP or the VNP. In terms of response rate, the response rates were vastly similar, but there was an increased rate of grade 3 hypertension, shortness of breath, acute renal failure, and cardiac dysfunction in the KMP group, which suggests that in this frail population we were seeing a lot of side effects, which may account for part of the loss of benefit that adding a carfilzomib could occur. So in terms of grade 2 neuropathy, that was lower in the KMP arm, so that was an improvement. And so this is a way, I think, an important trial to show and to tell that this is an example where side effects have outshone the benefit of a specific of adding a specific a new drug to a combination. So changing background, when we change backbone therapy, we now have another, which is Lendex. And this was developed in the IFM 2007-01 trial, or NN020, or first trial, which compared 3 different regimens. So it was continuous Lendex for a fixed duration, and MPT, which was at the time the standard of care. And so this is an updated results with a median follow-up of 67 months that was previously presented by Professor Falco-Matash. And what is important to notice that still 10% of patients were still on treatment at the time of analysis. And what one can see is it confirms the benefit in terms of PFS of continuous RD over both MPT and RD18, but also a benefit in overall survival. And when we look at this at the 4-year landmark, what we can notice is the improvement in overall survival of the 2 RD arms over the MPT. And so another set of data that could encourage us to continue lenalidomide to progression is that one seen by the British group in the Myeloma 11 trial. And they, in newly diagnosed multiple myeloma patients not eligible for some were eligible for transplant, others were not, and were either randomised to maintenance with either lenalidomide or observation. And they demonstrated an improvement in progression-free survival in the transplant non-eligible patients also, which would suggest the role for continuous therapy in these patients. Another trial that I tried to add to the backbone of lenalidomide was the one performed in Italy, where elderly newly diagnosed multiple myeloma patients were either randomised to a standard RD, to a combination of IMPR or CRP, and then randomised to either maintenance with lenalidomide alone or lenalidomide prednisone. And what was shown in that trial, that there was no significant difference in terms of progression-free survival and overall survival between these three groups, suggesting there again that any additional benefit that can be seen from adding a new drug onto a backbone is outshone by a significant toxicity. So the SWOG designed a clinical trial for the transplant-ineligible patients by adding into the backbone of lenalidomide dexamethasone bortezomib on days 1, 4, 8 and 11, and secondly performing secondary adding a lenalidomide maintenance. So what this trial demonstrated was a significant benefit of adding Velcade, a very well-tolerated agent, to the backbone of lenalidomide maintenance. Nevertheless, the median age of these patients was below 65, and a large proportion of these patients would be in Europe considered transplant eligible. So this furthermore, there are large phase 3 trials that are currently based on the RD backbone, with adding other agents such as antibodies like elotuzumab, daratumumab or pembrolizumab, and other proteasome inhibitors that have a much nicer tolerability. And so in conclusion, the availability of new drug combination has increased the treatment options for elderly patients, and I think I have convinced you of that today, and which has led into a significant prolongation of overall survival. And so NPT, followed by VMP and Lendex, represent new standards of care for these patients. And so other combinations are worth thinking of, such as RVD or novel proteasome inhibitors such as IRD, are also in clinical development. And so adding monoclonal antibodies such as anti-CD38, LAMF7 or PD-L1 in the future will help, probably will be of great help, and are currently under evaluation and under induction and in the maintenance setting. So maintenance treatment with novel proteasome, with novel agents is an emerging concept, either with proteasome inhibitors or antibodies, and is a new strategy to sustain disease control and delay disease progression, but it is important to individualise which patient will benefit from which treatment through a correct geriatric evaluation. Thank you for your attention.